All right, good evening, everyone. Can you hear me?
Yes, Prof.
Yeah, I think we should start. Today we'll continue where we started last week on the pain. And today we'll be looking at pain assessment. All right. Let me see how many of us we have 44. Okay. So let's do some of these our normal questions quickly. So a 56-year-old male patient intubated and sedated in the ICU is recovering from abdominal surgery. The nurse reports increased blood pressure and heart rate. Which of the following is the most appropriate tool to assess his pain? Anyone?
Behavioral pain scale.
Behavioral pain scale, correct. All right, second question. A 4-year-old patient child is in the post-recovery room after tonsillectomy and is crying. Which of the following is the most appropriate pain assessment tool?
Flack scale.
Flack scale.
Flack scale, correct. All right. A 32-year-old woman in labor requests pain relief. Before initiating analgesia, you want to assess her pain using a self-report scale. Which of the following will be the most appropriate?
Wambeka.
Wambeka. Do we all agree? Do we all agree? Wambeka, anybody? Wambeka is correct. Let's go. Okay, a 65-year-old patient with severe dementia is admitted to ICU after hip fracture repair. Is non-verbal, but grimaces and withdraws during nursing care. Which tool is best for assessing his pain? Anyone?
Visual analog. Visual analog.
No? No? Another trial?
Painad.
Painad, correct. Painad, correct. Painad. We'll look at that if we're able to get there today. Painad is the correct. Okay? Sorry. Number 5. The 45-year-old trauma patient in ICU is sedated and ventilated. You suspect pain during suctioning. Which behavioral indicators are used in the behavioral pain scale? Anyone? C, because of our time, facial expression, upper limb movement, ventilator compliance rather. So the last question, did we get that answer, number 5?
Yes, sir, we got it. Yeah, we got it, Prof.
Okay. So number 6, a 50-year-old man is in ICU after major abdominal surgery. Is awake but cannot speak due to tracheostomy. Which of the following is the most appropriate self-report tool? Self-report tool. Anyone? Hey, guys.
Visual analog scale. A.
A is correct. Correct. A is correct. Okay, so pain assessment is crucial in the management of pain. It also helps to monitor response to your therapy and prevent complications. Okay, so pain assessment involves both subjective and objective methods because pain itself is also subjective and objective, and it should be tailored to the patient's condition. In assessing pain, remember always that the patient's self-report is the gold standard. What does that mean? It is what the patient says it is. It is where the patient says the pain is that it is. So pain is very subjective, and patient's report is the gold standard in assessing pain. So there are some principles of pain assessment that we must always incorporate in whatever pain assessment methods we may be using. So we must assess pain regularly and consistently. All right? Pain must be assessed regularly and consistently. Your assessment of pain must be documented. All right? And pain assessment should be based on the patient's age, communication ability, and the clinical context. Also, you should use multidimensional approach, not just one pain assessment scale. All right, this will all help you to look at the intensity of the pain, the location, quality, and impact on the patient's activities of daily living or function. Okay, so there are different formats that can be used generally. That's what we call what's up format. You're approaching your patient and say, what's up? So W, where's the pain? H, how does the pain feel? Is it sharp or shooting? A, what are the aggravating or alleviating factors? T, the timing, when did this pain start? Is it continuous or it comes and goes? All right, S, the severity of the pain. U, other useful information, all right? Any other symptom associated with the pain? And P, how does the patient perceive the pain? So that's the what's up format. Then we have the OPQRST format. O talks about the onset of the pain. P, provoked, what provokes the pain? Q, what is the quality of the pain? Is it dull or sharp? Region of the body, and where does the pain radiate to? S is the severity of the pain, and T, timing, when does the pain occur? All right, so these are some other pain assessment format. You can use Socrates. So talking about site, where's the pain? Onset, character, radiation, depends on which one you want to use. The Q-stabbed also contains some other important things like the expectations. All right, it may look weird, but when you're asking your patient what is your expectation of your pain management, okay, goes on what does the pain mean to the patient, and D, the diagnostic and physical exam. All right, then we use pain itself. All right, so this incorporates other pain scores like the numerical rating scale and your visual analog scale. So the P is here stand from the place or site of pain. A, aggravating factors. And I, what the intensity. So you use your numerical rating scale or your visual analog score here. Okay, N, what is the nature of the pain and what neutralizes the pain? Okay, so we'll focus on pain assessment in pediatrics as we move on. All right, know that usually pain is recognized and treated in pediatrics because of difficulty with assessing their pain. All right, usually infants and younger children may not be able to verbalize their pain effectively. some time ago, I saw online how some people try to interpret infant's cry. All right, if the baby cries in a particular way, it means the baby is hungry. If it cries in a particular way, it means it's in pain. But all that are subjective. Okay, and that makes pain management in pediatrics very difficult. But for us to be able to manage pain appropriately and effectively, it's important for us to have tools that will allow us to have a proper assessment for pain and also to improve the patient's outcome. So there are two major types of pain assessment in children, all right, based on their age and their ability to self-report. So two of them, number one is self-report scale, usually reserved for older children, usually 3 years and above. And we have the behavioral observation scale. These are for infants or non-verbal children. So we're going to look at some of them. Under self-report, we have the FACES pain scale revised, all right? And we have the numerical rating scale, especially for the older children. For infants and those who cannot verbalize their pain, we use the FLAS scale. All right, we represent face, legs, activity, cry, and consolability. And we have the Children's Hospital of Eastern Ontario pain scale, the CHOPS. So basically, this is just the different types of pain assessment tools we use in children. So the first one we're going to look at is the FLAS scale, all right? This is a behavioral pain assessment tool reserved for infants, younger children, and non-verbal patients, okay? It's particularly useful when the patient cannot self-report his pain, okay? So population infants, all right? And then we have non-verbal children, adults who are sedated, intubated, or who are cognitively impaired. We may use the FLAS scale for them. So on the left is the table for the FLAS scale. Face, all right, you observe the face. If there's no particular expression or the patient is smiling, you give 0. When you have occasional grimace or frowning or the patient is withdrawn or disinterested, 1. All right, if there's frequent to constant quivering, chill, and clenched jaw, okay, you give the patient 2. Legs, is the leg well positioned or relaxed? Or is the leg uneasy, restless, and tense? If the child is kicking or the legs are drawn up, you give the patient 2. Activity, cry, consolability, these are the scales, all right, the parameters that are observed in FLAS scale. Interpretation, 0. Patient is relaxed and comfortable, no pain. 1 to 3, the patient is in mind discomfort. 4 to 6, moderate pain. When the patient is having 7 to 10, there's this severe discomfort and pain. So this is the FLAS scale reserved for assessing pain in infants and non-verbal patients. Yeah, the Wambaker FACES pain scale is a self-report tool. We saw that woman, that's a woman in labor. All right, we can show her the Wambaker FACES scale. Okay, so a self-report tool is widely used to assess pain intensity in children, adolescents, and adults who can communicate or may have difficulty with numerical skills. Okay, so for use in children 3 years and above, and in adults, look at the face, smiling face, no hurt. 2, hurts a little. But look at 8 and 9, 8 to 10. 10, you can see that there are tears in the face, so it means the pain hurts the most using your Wambaker FACES pain rating scale. Then we have the Children's Hospital of Eastern Ontario pain scale. It's a behavioral pain scale for evaluating post-operative pain in young children. Okay, it uses 5 parameters. Okay, cry, facial expression, verbal, the torso, and the legs. Okay, so the Children's Hospital of Eastern Ontario pain scale uses this, and the minimum score is 4, maximum score is 13. Look at, is the patient crying? No, 0. Patient is smiling, 0. Verbal positive statement, how you doing? I'm okay. All right. Torso, how is the torso? Neutral. Legs are also neutral, so that patient has 4. Okay. So that is my slide is not moving. Okay. The pain assessment scale, the other one is the cries. Okay, this is usually used for infants 6 months old and older children. And it's also widely used in the neonatal ICU. It assesses different parameters. Crying requires oxygen, increased vital signs, expressions, and sleeplessness. Okay, so it's the acronym cries. All right, and you have the different scales here. 2 points are assigned to each parameter with a rating of 0 for signs of no pain and a rating of 2 for signs of maximum pain. So this is cries. All right, so this is a table to just summarize the different pain assessment scales we've talked about. So for infant, there is no self-report, okay? All the pain scale for children are observational. All right, we even have the PIP, the premature infant pain scale, and all of that. Okay, in children, we can have self-report and observational, and adults, we also can have self-report and observational. We have some physiological scales, like the comfort scale and the one-term impairment and pain scale. So let's look at the one we're very familiar with, especially used in post-op period. Okay, we have the numerical pain rating scale, NRS. Okay, you can see the figure on the right side. It's a self-report tool that's widely used to assess pain intensity in adults and older children. It is simple, fast, and easy to document. Okay, so what do? You ask the patient, all right, to rate his scale, to rate his pain on a scale of 0 to 10. You draw this line and you see. So you explain to the patient what each numbers represent. 0, no pain. 1 to 3, mild pain. 4 to 6, moderate. 7 to 10, severe pain. All right. So this can be represented verbally, or you can tell the patient to touch which number, all right, represents or corresponds to the intensity of his or her pain. All right. The visual analog scale is also a self-report tool that is used to measure pain intensity in patients who are capable of communication, and that's why it's a self-report. All right. The beauty of it is that it provides a continuous measure of pain severity rather than discrete categories. Okay, so the VAS scale is usually a 10 centimeter horizontal or vertical line. On the left side, know that there are no numbers here. Okay, on the left side, no pain. On the right side, worst pain imaginable. So you ask the patient to mark on the line, all right, that best represents his or her pain intensity. Know that the distance from 0 on the left side to the right side is measured can be measured in centimeters or millimeters to quantify the intensity of pain. Then we have the Magee Pain Index or the Magee Pain Questionnaire, usually developed at McGill University by Masak and Dogison in 1971. All right, there are 12, a set of 20 descriptive words, 10 assesses a sensory component, 5 assesses the affective component, 4 of them assess describe miscellaneous, and only 1 set of words or parameters describe cognitive aspects of pain. Usually used for chronic pain, all right, and minimum pain score 0 will not be seen in any person with true pain, obviously. And we have maximum pain score of 78. Note that in interpreting the Magee Pain Index or Magee Pain Questionnaire, the higher the pain score, the greater the pain. Okay, on the right side, you can see the different descriptive words that are used: flickering, quivering, pulsing, throbbing, beating, pounding, all right, jumping, flushing, shooting, all right. These are descriptive words, all right, that represents both sensory and affective components of the pain, okay, and even one of them represents the cognitive aspects of pain. So the Magee questionnaire, although laborious, but it covers every aspect of pain assessment, both subjective and objective. Then we have the brief pain inventory. Okay, this also makes use of in chronic pain. I'm sure we may not be able to get to chronic pain again today, but it comprises of 2 aspects. All right, looking at pain intensity and how the pain interferes with the patient's quality of life. Okay, so the patients are asked to rate the severity of pain as worst, least, or average in the past 24 hours, and they must also report the time of the rating of their pain intensity. Okay, the brief pain inventory also requires patients to represent the location of their pain, all right, on a schematic diagram of the body, because it has to do with the interference with the patient's life. I also want to find out from the inventory, all right, how pain correlates with activity, sleep, or social interactions. Some patients in severe pain may not be able to sleep, and they may be withdrawn, not wanting to interact. Okay, so the brief pain inventory is presented on the right side of the slide. Then the other one is what we know as the pain thermometer. All right, I'm sure we're very conversant with the thermometer. So this is a visual analog tool, almost like your visual analog scale, and it represents a thermometer with markings with no pain at the bottom towards possible pain at the top. It's often color-coded: green for no pain, yellow for moderate pain, red for severe pain. Okay, so the advantage of this is that it has different words to describe the pain. No pain, slight pain, mild pain, moderate, severe, extreme. And the last one, the red part of the thermometer, is pain as bad as it could be. Okay, so pain assessment in ICU is also very tricky. All right, because most of the times they are sedated, they can't verbalize their pain. So different pain assessment tools have been developed specifically for use in the ICU. So we have the behavioral pain scale, which was specifically developed for mechanically ventilated patients. All right, it has 3 domains, like you can see on the right side. Facial expression, patient is relaxed. Score 1, partially lightened or brow lowering. Patient is fully tightened with eyelid closing. And there's grimacing on facial expression, so you can see that. The other one is upper limb movement, like the question I asked initially. These are the components of the behavioral pain scale. Facial expression, okay? Upper limb movement, okay? No movements, partially bent, fully bent with finger flexion, permanently retracted, okay? And compliance with ventilator. Patient is tolerating. Patient is coughing, but tolerating ventilation for most of the time. Patient who is fighting the ventilator will have a score of 3. And patient who is unable to control ventilation, they have 4. Okay, the score ranges between 3, no pain, and to 12, maximum pain. So the compliance with ventilator is what makes it unique for ventilated patients in the ICU. Then we have the CPOT, which is critical care pain observation tool. All right, this is also designed for use in the ICU and assesses 4 behaviors: the patient's facial expression, body movement, muscle tension, compliance with the ventilator for those who are intubated and ventilated, or you use vocalization for those who are intubated. So the CPOT kind of also caters for patients who are not ventilated, all right, who may be able to, especially those who have talking tracheostomy tubes, they may be able to vocalize the level or the intensity of their pain. Okay, the last one we're looking at in ICU is the non-verbal pain scale. Non-verbal pain scale. Okay, there are 5 domains rather: the facial expression, movement, guarding, physiological indicators, and respiratory indicators. All right, the score ranges between 0 to 10. All right, this is for non-verbal pain scale. So let me stop here and take some questions before we go for pain management. Any question on pain assessment thus far?
Good evening, Prof.
Good evening.
Yes, I had a question on the CHEOPS score, the child.
The what?
The CHEOPS score.
The CHOPS, the
Yes, the
Children
CHOPS. Yes.
Hospital of Eastern Ontario. Wait, I'm going there.
Okay.
Where am I? Sorry, I'm trying to locate it.
That's fine.
Where is it? Okay, this one.
Yes. You said the minimum score is 4, but I do see a column of score 0 on the table. So how is it that the minimum score is 4 and not 0?
Yes, I expect somebody to mention that. So the minimum score, that was a mistake. The minimum score should be 0. Okay?
Okay.
After I
Thank
said
you.
it, I was expecting that somebody would bring me back to read.
Okay, thank you.
All right, thank you, Yanko. All right. Any other question?
Good evening, Prof.
Good evening.
I'm Dr. Abayomi White from Nigeria. I want to ask, is there any difference between pain assessment tools and pain assessment skills? Tools and skills.
or skills.
Tools and skills. Is there any difference?
There is a difference, all right? Skill has to do with ascribing some objective parameters, okay? Tools there are other ways. Those ones may not have, objective parameters or scores. For instance, now if you see the numerical rating scale, all right, there's a scale. Most of these other ones, the VAS-COL or VAS-K flag has a scale, but there are some that are used that do not have the objective scores attached to them. All right, I hope that helps to answer the question.
Yes, Prof. Thank you very much.
You're welcome. Any other question? Okay, if there are no questions, do I take it that we can assess our patient's pain correctly going forward, adapting it to different patients' needs and patients' characteristics? Is that taken for granted?
Good evening, Prof, sir.
Good evening, Dr. Olayinka.
Yes, sir. Thank you, sir. Sir, my question is about the McGill pain scale, sir.
Okay, let me go there. Hold on.
Yes, sir.
Okay, here. Yes, go ahead. Hello, Dr. Olayinka, we're here.
Yes, sir. Sir, so as much as these scales are we giving them to the patients to tick or fill by themselves, or we are the ones that will be observing the patient and ticking the score?
It's a questionnaire, all right? Most of the time, the patient is a chronic pain score, so the patient should be able to, it's both sides, all right? The patient and, like when you even give your questionnaire for studies, some of the times the respondent may ask some questions, but it's both sides, both the patient and the clinician assessing the pain. Okay?
Thank you, sir.
You're welcome. But most of the time, let the patient do most of the work, all right? In terms of, answering the questionnaires and the question, okay? All right, let's go ahead. And if there are no other questions. Okay, so pain management. All right, so this is, as an anesthetist, this is the core of our practice. All right, this is the core of our practice, managing pain. All right, taking people's breath away and returning it back to them. That's what we do. All right, so the first principle of pain management, especially in anesthesia and critical care, is what we know as the multimodal analgesia. All right, it's a concept, all right, that talks about the use of two or more analgesics or techniques, all right, that add a different sites in the pain pathway to achieve superior pain control with fewer side effects. So it has a standard definition. So two or more analgesic agents or techniques that are acting on two different sites in the pain pathway. We spent some time last week talking about the different pain pathway, right from the the beginning, okay, of the sensory pathway, all right, down to the brain where brain perception takes place, okay? So you can imagine if you're given two NSAIDs that are working on the same side, that is not multimodal, okay? Multimodal analgesia is when you're giving two or more drugs working at different sides or act by different mechanisms. All right, and the pain pathway, that is when you are practicing multimodal analgesia. And the beauty of it is that it achieves superior pain relief with fewer side effects. The rationale behind multimodal analgesia is because we know that pain is a complex thing and is multidimensional, involving peripheral, spinal, and central mechanisms. Okay, so the use of multiple drugs or agents and techniques that target different receptors and pathways. All of these will reduce reliance on opioid, minimizing adverse effects, and it helps to enhance pain relief, facilitating early mobilization and recovery. Okay, so multimodal analgesia, like we said, can add at different levels. Okay, NSAIDs, paracetamol, they act at the peripheral nociceptor site, where they help to inhibit the production of prostaglandins. Local anesthetic agent also helps at the peripheral nociceptor site by blocking sodium channels. We have opioids, all right? Opioids work at the spinal cord or the dorsal horn, the substantia gelatinosa, all right? I hope we still remember lamina 2, okay? Activates mu receptor agonist. Then we have the NMDA antagonist, ketamine, and desmetophan, all right, which help to prevent central sensitization. The alpha-2 agonists, all of these are acting at the central spinal cord or dorsal horn. Opioids, all right, and acetaminophen, the paracetamol, which has central cause inhibition pathway. All right, all of this modulate neurotransmission and also helps with cognitive behavioral interventions. I remember those days as a resident when I first came across opioid, the mechanism of action of opioid in using analgesia. The issue is that the pain is there, but opioid kind of modulates the brain's perception of pain. And I wonder what kind of drug does that. The pain is there, but it's making you not to feel the pain. So that is the beauty of multimodal analgesia. Other things like the peripherally active one will inhibit prostaglandin production. All right, so actually, affecting those receptors' perception of pain. So there are different components of multimodal analgesia. We have the pharmacological and the non-pharmacological approaches, all right? So the pharmacological approaches, opioid, which is the gold standard for the management of acute pain. You have your NSAID, which can be, the generic COS1, COS2, or the specific COS2 inhibitors. All right, paracetamol. All right, I hope we know that paracetamol is not considered as an NSAID. It adds through a different pathway, all right, especially centrally. Local anesthetic agent. Then we have adjuvants, like your NMD antagonist, your alpha-2 agonist, and the alpha beta calcium channel blockers, like your gabapentin and pregabalin. So multimodal approaches, all right, we have the cold or heat, physiotherapy, and all that. And this is important, all right, especially for ICU. For patients who are in pain or delirious or agitated, I always try to ensure how we can do environmental modification, all right, or conditioning to help with the pain. So it's important. All right, analgesics is not just pharmacological agents. Non-pharmacological agents play a role. So what are benefits of multimodal analgesia? All right, it's because it leads to enhanced pain relief through additive or synergistic effects of different agents that are employed. Okay. Then we have another one which is important, reduced opioid consumption. All right, and we're going to see some of the side effects of opioid. All right, improve functional recovery, early mobilization, shorter hospital stay, reduce cost of healthcare. All right, and reduce the risk of chronic pain after surgery. All right, poorly or undertreated acute pain can lead to chronic pain. So opioids are the mainstay, like I mentioned, of acute pain. And morphine is the gold standard. We looked at it before. It acts at the level of the spinal cord, the dorsal horn, all right, by inhibiting calcium influx pre-synaptically, because it leads to potassium efflux post-synaptically, all right, and in the heart activates the descending inhibitory pathway by inhibiting GABAergic pathway. Okay, so there are different opioids that I'm sure we are familiar with. The naturally occurring, the morphine, codeine, and terpene, and we have the synthetic, pethidine, fentanyl, and tramadol. All right, we have the semi-synthetic, the heroin, osmophone, and hydrosmophone. Okay, and remember that opioids are not without adverse effects. Okay, morphine being the gold standard. I use morphine as also the mnemonics for side effects of opioids. So M, meiosis, O, you reduce the C, constipation, R, respiratory depression, P, physical dependence, I, itching, nausea and vomiting, okay, and E, euphoria. All right, you may have some other side effects that are not here, but these are, especially for my medical students, these are enough for me to give them full marks. Then there's a phenomenon known as the opioid-induced hypergeusia, OIH. Although it's rare, patients who are on opioid, all right, may become more sensitive to pain despite being on continued treatment with opioids. Usually common with morphine, all right, and changing to other opioids, such as fentanyl or remifentanil, usually can help. So if your patient has been on morphine for more than 2 weeks, all right, and your pain score, especially those who are in ICU, using your CPOT or your PPS, and it shows that there's pain, this patient may have developed what we know as the opioid-induced hypergeusia. All right, but co-administration of ketamine, for instance, the NMT antagonist, can help to abolish opioid tolerance, opioid-induced hypergeusia. All right, the second agent we use, the NSAIDs, all right? Okay, mechanism of action is by inhibition of the cyclooxygenase 1 and 2 enzymes, which are responsible for converting arachidonic acids to prostaglandins, and that is what we use. That is mediate pain from the nociceptor peripheral side. All right, prostaglandin E2 is the key mediator for peripheral and pain sensory sensitization. So NSAIDs work peripherally by inhibiting the production of prostaglandin E2. There are 3 different types. All right, like I said, sometimes acetaminophen, paracetamol is not considered as NSAIDs. All right, then we have the ketorolac, piroxicam, and what have you. These are cause 1. All right, they are, sorry, let me put it away. They are not specific cause inhibitors. We have the newer ones who are more cause 2 inhibitors because they have better GI and renal effects. They cause 2 specific. All right, so we have different side effects of NSAIDs. Let me just leave this because of time. Okay, then we have the other ones, the NMDA antagonist ketamine, for instance, all right, which at sub-anesthetic doses can help reduce opioid dependence, reduce total opioid consumption, all right? Dextromethorphan, also used as an antitussive, is an NMDA antagonist, all right? And it can be used to reduce your patient-controlled analgesic morphine requirement. Okay, so these are some of the side effects of ketamine. Is on the group, what's it called? The WhatsApp group. It's there. That's where I got it from because I sent it earlier, so you can look at it from there. So the alpha-2 agonist, all right, this helps to reduce the release of norepinephrine. All right, remember that norepinephrine is one of our neurotransmitters, all right, in the pain pathway. So reduction or reducing the release of norepinephrine helps to mediate analgesia while producing anxiolysis and sedation. So we have the two common alpha-2 agonists, the clonidine and desmetomidine. All right, desmetomidine is a highly selective alpha-2 agonist, which is about 8 times more selective than clonidine and provides titrable sedation, analgesia, and anxiolysis without causing significant respiratory depression. All right, it's excellent as an opioid-sparing agent in multimodal approach, but know that high doses may also cause severe bradycardia and may also predispose the patient to asystole in high-risk individuals. Okay, we have the alpha-2 delta calcium channel ligands, the gabapentin or the pregabalin. All right, these agents bind to the alpha-2 delta subunit of voltage-gated calcium channels in the dorsal horn of the spinal cord. So once they bind, it causes reduction in calcium influx at the presynaptic terminus, all right? And this leads to reduced release of excitatory neurotransmitters. Remember all of this last time, all right? You know, most of the times, these agents are used in the management of atypical pain or patients who are in ICU. Some of them have chest pain, maybe because of prolonged lying and all that. And these agents have been found to help, you know, when used in multimodal pathway. Okay. So there are different modalities of delivery analgesia. We have the bolus, okay, and usually very useful because it causes rapid onset of effect. It's simple and not very cost effective. The problem is that it can lead to fluctuating prey control because of the peaks and troughs in plasma concentration of the agent. All right. It may also lead to increased risk of adverse effect. For instance, if you give morphine 5 milligram IV every 2 hours, it's going to accumulate and you may have respiratory depression. While the continuous infusion, the advantage is that it helps to maintain steady drug levels, all right, reduces pain fluctuation. But in patients with multi-organ failure like we have in ICU, there's always a risk of accumulation and resultant toxicity. So because of this, it requires careful monitoring. We have the patient control analgesia, all right? This is a computer-based device that allows patients to self-administer preset or predetermined doses of their opioid analgesics through a pump, all right? There are other tutorials where we focus so much on these modalities of pain relief and all that, how to initiate them, okay? There are 3 key features of PCA, All right, it has a bolus dose. Then we have the lockout interval. All right, during this period, no matter how many times the patient presses the demand button, no opioid will be delivered to the patient. We have an optional background infusion for those who are in severe pain or patients who have cancer pain. It helps to improve patient autonomy, all right, saying that your analgesia is in your hand, all right. Also helps to relieve breakthrough pain and reduces nurse workload. Okay, but the advantage is that it's not applicable, it's not useful for all patients because it requires patient to understand, all right, and be able to operate the device. Obviously, because of this, you don't want to use it in confused or very young patient. Then we have the nurse control analgesia, all right, especially indicated in patients, young patients, patients who are unable to use PCA, especially in our ICU, patients who are sedated and unconscious. Disadvantage is that it's labor intensive, and sometimes we prescribe an analgesic and it's not given because of the patient's workload. All right, so this may cause delay in pain relief and untold suffering to your patient because they depend on the nurse for their pain relief. Okay, I think we should stop here. We still have some chronic pain, I think, which we would, I think we'll just finish next week. Okay, so any question? I think we should stop here today. Any question, any comments before we close? Let me stop recording.